Started now. All right. Good morning, everybody. I am very pleased to introduce one of our stellar fellows who is a third-year combined internal medicine and peds ID fellow with UCSD and Rady. This is Adriana Guiliani, and she's current and will continue to be a chief fellow in the adult ID program. She's currently doing vaccine immunology research under the tutelage of Dr. Pia Panaraj, evaluating post-COVID vaccine T-cell response across the spectrum of ages. She has an interest in viruses and immune response, completing 2 reviews on opportunistic viral infections in the past year and a book chapter on live viral vaccines pending publication. Her current intention is to enter into NGO or public health work after graduation in 2027. Thanks, Adriana. I will turn it over to you. I think, yeah, there you go. And I'll keep the chat on for you, so you don't have to worry about it. And I'll let you know if there's something that needs to be answered now. Otherwise, we'll save it for the end.
Hi everybody, good morning. I'm Adriana, like she said. And I'm going to be talking about measles, reemergence, and implications for adults and immunocompromised populations. I have no disclosures. But I will say I was able to attend the measles summit with my PI, Dr. Pia Panaraj, this year, which was very elucidating and helpful to understand kind of what's going on with measles globally within the United States and where they're going to be able to take this as we continue to address the current kind of epidemic. So my objectives are listed as follows: look at the epidemiology within the United States and globally, discuss presentations specifically within the immunocompromised populations and related neurologic complications, review current vaccine recommendations, and then look at what are the current approaches to treatment. So to just kind of remind everyone of like what measles is, again, this is like kind of a viral, usually rash producing illness that can create complications of primary, secondary pneumonia, hepatitis, neuro complications as well. Prior to vaccine introduction, there was 5 to 8 million deaths per year, and that's particularly because of this R naught or the R0 up here, meaning that for every one person that is infected with measles, they can pass measles on, transmit it to 12 to 14 other people. So it's the most infective virus, and that's why it was had such a high morbidity mortality in the past. So looking broadly, 1963, when both vaccines inactivated and live were licensed, where you can see a sudden steep drop off, control of measles, and still relative control compared to where we were. And again, this was a point before which there was like 5 to 8 million deaths a year. However, this is just in the United States, and luckily the CDC is still providing this nice data for us. You can see that in the last 10 years, a couple of these are like the Disneyland, kind of epidemic and things like that, outbreak. But in the last 2, things have been popping up in kind of school-based settings and these kind of local closed settings. But in the last year, whereas in 2000 we had been declared eliminated, meaning there was no endemic transmission of measles over a year, in 2025 and 2026, we have been having ongoing transmission. We haven't officially lost the elimination status as far as I can tell, but essentially have lost that. And just even in the past 2 years, you can see how 2025 in March, we were going through this big wave. It was continuing, and that's continued even through January, February, and even in higher amounts. And why is this relevant to the adults? Because we usually think about measles, we think about little kids. And this is primarily, these epidemics are primarily affecting that 5 to 19-year-old and over 20-year-old population. So 30% of cases we're actually seeing in adults. So I think that's really something that we need to keep on our differential, especially when dealing even with adult patients. And the majority of the cases are because they're unvaccinated and unknown, as I came to understand at the summit, is generally they're all unvaccinated. They just they have nothing. And to date, you can see in 2026, we already have 2,104 cases. This is as of last week. Last year, in the full year, there was about 2,300. So we're already almost to that number. What is this related to? This is related to ongoing transmission.
Adriana, I actually already have a question. I'm
Yeah,
sorry. The slide before, so this unvaccinated or unknown with an adult, like I understand with a child that's probably easy to access that record. With an adult, as someone who sees adults, and unless they were born in California or are traveling with their, they have their yellow card, you don't necessarily know. And so how I would think there is actually more unknown for adults, but is there a different assumption there or is it, yeah,
you can presume vaccination status. There's like a list of a couple of like alternatives to vaccination status that wouldn't qualify for unknown, being born before 1957, or report of having had like measles in the past or reported vaccination, or also measles antibody can be used.
okay.
So the unknowns wouldn't really follow under that
Got
category.
it.
Yeah.
Okay, so they'll check in antibodies
Hola.
tested in that situation. Okay,
Yeah, I don't know if they were checked in like because this is like throughout the country, so it depends on like
right.
what what they were able to do or got done. But those can be kind of substitutes for known vaccination status.
Okay, thank you.
Um, so in
Someone else
Cal,
unmuted, but I don't know if they have a question. Dana? I'll just mute. Oh, I can't mute them. You're good. Sorry.
in California, again, this is to date 2026, we've had 48 cases. A lot of these cases, I think a lot of people are probably aware. We have ongoing endemic transmission in small communities in Utah and South Carolina and in Texas. Um, and part of it is related to like overall vaccination status. We use 95% as the cutoff for kind of herd immunity because, again, of that R naught, it's so infective that you need 95% in the overall population in order to be protective. However, obviously, statewide numbers are not reflective of those small pockets of communities that are probably under-vaccinated or not well reported. And so while California looks like we have good vaccination protection, that's not reflective of, all over the state. And you can see overall our numbers are waning. And since about 2018, the vaccine kind of percentage has overall been dropping down. This is not just true of the United States. Canada has been dealing with a lot of cases as well. To date, these are both grabbed on the same date about a week ago. So 1,000 cases to date in 2026, largely in Manitoba. And I'll just point out Ontario here because I'll just briefly mention it later. And most of this, again, is endemic transmission, 97% being persons that were exposed in Canada. And I'm not going to be able to have time to go into this, but they also have had cases of congenital measles that have been confirmed, with one death in that population of congenital measles. And then in Mexico, and these are 18,000 cases in 2025 to 2026, largely in the Chihuahua region here. You can see kind of like where we've got TJ up here, there's still, a higher burden of cases than some of the places that are zero or unreported. And the reason that I kind of pointed out Chihuahua as well as Ontario is because interestingly, in Texas, one of the things I learned at the summit is there's like this large Mennonite population who largely in Chihuahua, like they travel from Chihuahua to Texas to Ontario, and it's not necessarily pertinent to their religious beliefs. There's not like an anti-vaccine belief that's necessary in Mennonite and Amish cultures, but really their vaccine beliefs are driven by kind of the peripheral people that they deal with or where they deal with kind of the rest of their community outside of the Amish community, like approaching, cities and towns. A lot of times they're more rural folks who might have certain ideas about vaccinations or be undereducated on them. And so a lot of their beliefs then are driven by those connections, not necessarily from anything inherent to their own population. But they travel regularly between Texas, Chihuahua, and Ontario. And we know that there have been some cases that have spread between those three areas because of that connection. And then also importantly, within the Amish communities too, there is known to be like a lot of medical tourism in Tijuana. So obviously, I just say that as kind of a risk to San Diego because if there were unvaccinated persons going to Tijuana for medical tourism, you can see how that could easily become an outbreak and spread up to San Diego a little bit more.
Adriana, sorry, Nettie just made a comment. She was surprised. Oh, yeah, you know what? I'll come back to this. There was a comment about Mexico, but we'll save it for the end. So
Yeah.
you can keep
A
going.
lo- yeah, a lot of the what's going on in Mexico is it's those small rural and indigenous communities that are or under vaccinated. That a lot of these are blooming kind of from that they haven't been able to get good control over at this point. And the numbers are very, very large. I actually met a public health worker from TJ who had basically like part of his job is he's on every WhatsApp school group where anything was being reported to try to like manage and make recommendations for vaccine and things like that. But the numbers are just so high that it's a lot to deal with still.
Yeah, so the
Uh,
comment that was made is that they have very high school-based vaccine program or excellent school-based vaccine programs and high vaccine rates. And then Fernando made a comment, you can't enter school without full vaccination and there's no homeschool. So how
yeah,
would this be happening? Is this
yeah.
areas where kids aren't going to school?
I was told that this was like largely from the indigenous and rural
Okay.
populations. Yeah. Um, so and then just in the Americas in general, is this because before all of the Americas had elimination status, and primarily it's still driven by the North America. So Canada, Mexico, and the US, there is some cases going up in South America, primarily in Bolivia, but otherwise still kind of fairly controlled. And internationally, though, how are things going? And you'll just see the region of America since the 2018s, pre-COVID, our vaccine status suddenly dropped off from 84 to 72%, and we just haven't recovered. Other places like the region of that, this is from the WHO, the region of Africa, the Southeast Asian region, like have actually had improving vaccine status. The Western Pacific, and European and Eastern Mediterranean have all kind of maintained. But specifically in the region of the Americas from 2018 to 2019, we made a significant drop off. And obviously in California, most recently, there's nothing current in Southern California really. In May, there was one case in Los Angeles. And one of the things I like to look at sometimes is the San Diego wastewater reporting. And there is currently no measles around San Diego. This is specifically looking at measles in the wastewater to see if there's any undetected cases going on. There was, you can see, I just like labeled here, Riverside had measles detected back in January. There's some ongoing kind of cases around Sacramento, but San Diego currently has been clear. So how is this relevant in, or more relevant in immunocompromised populations? So just thinking about the pathology or the pathogenesis of measles, it uses different receptors to infect different cell types kind of through its life cycle. And so it comes in through your dendritic cells or so like your skin cells or through the lungs, it infects those and then it spreads to the lymph nodes to infect lymphocytes, mostly CD4 T cells. And from those CD4 T cells, that's how it disseminates through the circulatory system. It gets back into your respiratory epithelial cells, and then that's how you spread it to other people. You release viral particles into the air. They have done mouse studies that found that profound CD4 T cell depletion increases the severity of CNS viral infection in mouse models as compared to CD8 or B cell deficiency. And that, again, that makes sense if you already have like a CD4 problem. That is one of the cells that they like to target and deplete even more. And you're going to have more difficulty because your body at the end of this course is not going to come back up and be able to like elicit an effective enough response. And then I'll just mention this, I'm not going to be able to go into it, but immune amnesia is a known phenomenon. The mechanism is not fully elucidated, but basically it cuts out your memory T cells and B cells. It's just like indicating that it's cutting down on the memory that you have against other diseases. And so this can have a big impact in like the 2 years after a measles infection. You're at increased risk for serious infections of other kinds because the measles virus has just depleted your B cell pool and your T cell pool as well. So what does this mean for presentations? This is specific to immunocompromised populations. They might have higher rates of primary and secondary vaccine failure. You can have late onset of a rash or no rash at all because the rash itself is a perivascular lymphocytic infiltration, and you can have prolonged viral shedding, which is important for infection control. Because typically we think 5 days before the rash, 5 days after the rash, that's your contagious period. But if you are immunocompromised, you might continue to shed beyond that and put other people at risk. This was a study. This was actually a really nice study, 2019, comparing persons living with HIV versus not adult patients with measles and how they were presenting. And I will say in this study, they presented very similarly. There was a smaller N for the patients who were HIV negative, but fever, rash, and red eye or conjunctivitis was still primarily what was being presented. Now, these were patients that primarily had well-controlled HIV. One of them did not present with fever, and they might be a little bit more likely to present with, or less likely to present with some of the GI symptoms as the HIV negative patients presented. But significantly higher to have any complication, even with well-controlled HIV. So 50% had a complication, with a third of those being, a third of patients being pneumonia and also ICU care or high care admission. Where did the report of like without rash kind of come through? That was from a review from 1992. Review, and it was like kind of a review of like all of the kind of case studies so far, included 27 cases of persons living with HIV, 16 in Africa and 11 in the US, who were then analyzed separately. And in the US cases, again, this is 1992, so you can kind of think about where that is in the context of the HIV epidemic. But 27% were without rash, high numbers of pneumonitis, so high numbers of complications, of 3 deaths. In the cases in Africa, the rash was not really described, but again, high cases of pneumonitis and 5 deaths. So that's kind of where some of that comes from and how relevant that is to a population with like better controlled HIV, unclear, but I think we still need to maintain a higher index of suspicion, even if you don't have a rash. This is a big slide. This is one of my charts that I made for a CNS opportunistic viral infection, just for your own kind of review later. But I wanted to focus in on, there's basically 4 neurologic presentations of measles. Really, they think that's more along a spectrum. It's not 4 distinct things. Acute primary encephalitis, you can imagine that's you have acute measles, you develop acute encephalitis. You can get kind of a post-infectious, kind of an autoimmune encephalitis. But the 2 I think most relevant or important to at least be aware of are the latter 2. The first being measles inclusion body encephalitis, MIBE, which is specifically associated with immunocompromised patients, especially ALL, but also in patients living with HIV who have a transplant or other cancer. It's related to just measles persistence in the CNS, and it can occur months to years after initial infection, usually more along the month scale, but it's rapidly progressive, and rapidly progressive encephalopathy, seizures, and progression to death, and there's really no treatment. So the mortality rates are really high. SSPE, which is something that traditionally you hear about talked about in pediatrics and not in adults, but there is evidence that it occurs in adults, although more rarely. Usually it's from measles infection when you're really, really young, especially the less than 12-month period. And then it can appear usually 7 to 10 years after, as this non-infectious form of wild type measles. So you're not going to get this as like a consequence of the vaccine or anything like that. It's wild type measles only. And it's just gradual cognitive decline, seizures, and also progression to death. There is a little bit more like specificity, or like there can be like alterations in that general kind of report of the presentation. But that's generally it's also just it's a gradual kind of decline over 2 years. And they've tried multiple treatments with some at least slowing of the progression, but nothing is actually effective as treatment. And so in terms of actual treatment, I know at the summit they didn't want to make an actual recommendation at the time because ethically, with how declined some of these patients are, do you want to delay their inevitable kind of death at that point? Like, are we just increasing their suffering as a question? So it's hard to make a recommendation, but there has been compassionate use of some antivirals with, again, possibly slowing down the progression. The reason I also mention this is because there's suggestion, like I said, that this can occur actually more frequently in adults and it's just unrecognized, presenting as a type of dementia. So it's essentially a diagnosis of exclusion. There are criteria used as diagnosis where you can find the measles, the specific measles type in the CSF, imaging findings, things like that. Some stuff that this is like a very old school, like the criteria were established in the 1970s, and they haven't been updated. So actually it's something that I know they're working on now, is to update what is our actual diagnosis, because this is unfortunately something that we might see a little bit more commonly in the next decade. Prevention. So vaccination, obviously, as everyone probably here knows, it's a live viral vaccine, but it's highly effective. Usually recommend 2 doses, but even with a single dose, you get 90 to 94% effectiveness. That second dose, beyond the toddler period, was recommended due to failure. There's 2 types of failures. Most of that was the primary failure. It's the maternal antibody kind of taking care of the vaccine at that 1 year period, which is usually when we give it in infants. And so you get a low avidity IgG and a poor immune response. But you can also have secondary failure where you get waning or incomplete immunity. And if you do have failure of vaccine, you still generally have modified measles infection if you do get the infection, where you have a lower viral load and mild symptoms. And as the listeners here probably know, it's, again, live attenuated is contraindicated with a CD4 less than 200 or less than 15%, as you can get kind of vaccine type measles infection. So one of the questions is, do you need to revaccinate? So the WHO does recommend giving an additional dose of measles vaccine to children living with HIV who just got immune reconstituted. As far as adults go, it's a very soft recommendation. It can be considered, but it's not strongly recommended. That data is coming from a couple of studies. This systematic review took a look at measles seroprevalence and the immunogenicity, and finding that generally the measles seroprevalence among adults and adolescents living with HIV across 27 studies had very similar kind of seroprevalence between adults living with HIV, or those living with HIV and those without. So it looks like the antibody is still present. It did show in 5 of the 9 studies that the antibody level is lower, but it's still in the protective range. So that clinical difference is likely negligible. So overall, it looks like once people have immunity to measles, it is maintained at a similar level compared to the comparative otherwise healthy population. And in terms of immunogenicity, there's the immunogenicity of the vaccine ranges. It is a lower kind of range compared to persons without HIV. But again, you end up with that higher that regular kind of seroprevalence. So overall, they said the reviewed studies do not indicate a need for revaccination, given that similar seroprevalence and then the low immunogenicity of the vaccine itself. As you can imagine, these are small studies with few people, but they were kind of looking at the number vaccinated and the number seropositive at the end. And it's kind of arranged with the more recent studies showing, which this last one, unfortunately, just the comparator population is only an N of 2, but had a similar kind of positivity, about 56% in persons living with HIV at the end of 48 weeks, so almost to a year, versus those living without HIV. And this is kind of also a summary of of that, looking at post-vaccination waning immunity, where the darker kind of lines are those living with HIV and the gray ones are without. But you can see even the ones that are gray, persons living without HIV, they are also having waning immunity after vaccination. So that's just going to be a normal part of it. Post-exposure prophylaxis is recommended usually within 72 hours, ideally, but can be done within 6 days of exposure. And again, what's recommended is based on the CD4 count, or also if patients are currently pregnant, you can't give them the live measles vaccine. So immunoglobulin is what's recommended. Is it helpful? Probably, but there's very limited studies, and again, specifically in the pregnant and immunocompromised and even adult population. This was a nice systematic review done in 2025. So a recent systematic review showed that there's like really 9 studies. There's poor reporting of like how extensive the exposure was, what was the time to treatment, what was the dose of immunoglobulin. And overall, they concluded there was like moderate serious concerns of risk of bias throughout these studies, but showed that generally with immunoglobulin, it was 76 to 100% effective, and measles-containing vaccine, or MCV, was 80 to 100% effective. But again, very limited. You can see in none of these, I don't think any of these really included persons who were immunocompromised, and few of them with adult population, and only one of them had it was a case report with a pregnant adult. So while it is limited data in the adult population, it is highly effective within the pediatric population and is felt to be effective in the adults. So we've talked a while about measles. You're gonna, have more complications, be more difficult to treat, to clear in the immunocompromised population, or might be at increased risk. So what do we have to treat it? So I think everyone's heard of vitamin A as treatment, and that is a WHO recommendation that adults and children get 2 doses of vitamin A supplements within 24 hours. It is well established, at least, or it was, that vitamin A deficiency is a risk factor for severe measles, and that measles itself can reduce vitamin A serum concentrations in previously well-nourished children. So that's this on the right. This was a 2000 study looking at well-nourished versus malnourished. You can see in the well-nourished children had a retinol level, or like a vitamin A level, of 100%, for those who didn't have measles. Obviously, this is not like a pre-post cohort. But those who were reported to be well-nourished, who had measles, dropped to 69, which is even lower than those who were considered malnourished. So measles by itself can cut down your vitamin A levels, and there are various possible mechanisms for why that's happening, but that has been shown. So does vitamin A help? So there's a couple of studies looking at this. This is from 1990, randomized controlled trial of vitamin A in children with severe measles. And they noted low vitamin A serum levels in 92% during illness, despite general rarity of vitamin A deficiency in the population. This is a population in South Africa. But they did note that the vitamin A group recovered more rapidly from pneumonia and diarrhea and had fewer days in the hospital, and that the placebo group had higher mortality. And this is kind of looking at, and it was 189 children, so a good kind of group looking at that. And this includes that data that I just talked to, but 97 in the placebo group, 92 in the vitamin A group. And you can see 2 deaths here. And again, the rates of pneumonia, diarrhea, and also intensive care was higher in the placebo group. So what has this continued to lay out in that way? 2005, they did this nice review of 8 trials of vitamin A treating measles in children. This review, though, showed of this 2,500 patients reviewed, there was actually no significant reduction in mortality risk. A single dose, especially, no associated reduction, but for giving 2 doses, which is the current recommendation, in children less than 2 years old, it reduced mortality, pneumonia-specific mortality. Anybody above 2, it doesn't seem to have an improvement, but in that very young group, it did seem to change outcomes. And so how relevant vitamin A is to children older than 2 years old or adults, it's still kind of under debate. This was an interesting study because this was done in Italy, published in 2021. It was looking at cases from 2015 to 2018 in Italy, where they do regularly have kind of like imported cases, small epidemics, and they don't always have enough vitamin A. And so some ways it was more of a randomizing or like patients, not in a non-blinded manner of giving vitamin A or not. 95% of children were not immunized. They enrolled 108 children. 36 received 2 doses of vitamin A, 72 matched controls received standard of care, which is essentially placebo. And they actually did not find in this Italian population that there was no significant difference in fever, length of hospital stay, or complications. And this is kind of where they're looking at that, and also tried to delineate out between in subgroup analysis. But you can see even children below 24 months of age, which is that 2-year mark, there was no significant, like you get close to significant maybe with hematologic complications, but that's still a P of 0.07. And then children with underlying chronic conditions also not reaching significance. And then this is looking at the risk ratio of pneumonia, of different things compared to vitamin A and standard care. And all of these, as you can see, cross the midline, meaning that they're not getting significance. Maybe you could say that some might be trending one way or the other, but again, we're not gaining significance for any of these in this study. So what about not vitamin A therapies? What else do we have? So ribavirin, I think, is something that gets considered or talked about a lot. It inhibits in vitro measles replication. And there have been several studies on the effectiveness of ribavirin plus or minus. 1981, unfortunately, this text is no longer accessible, but there was reported to be a double-blind placebo-controlled study that reported more rapid resolution of disease and fewer complications. 1991, there was actually 2 studies, this one's specific to ribavirin, but there was another study actually of earlier that I mentioned briefly earlier. I pulled data from earlier of persons living with HIV and persons with cancer that they just showed. They were like, as an observation, they're like, hey, the patients that had ribavirin seem to recover faster. We should look into that. This is an actual study, 1991, in New York, 6 adults with severe measles pneumonitis treated with IV ribavirin for 7 days, including 2 persons living with HIV, and did show improvement in respiratory status for those treated by day 2 to 5 of illness, and 1 death. That 1 death was a person that was treated later, so after that 2 to 5 day of illness. And again, those were adults. 2011, in India, there was a randomized controlled trial of 100 patients, 6 months to 47 years old, with oral ribavirin that did show, again, reduced duration and severity of symptoms and no complications or mortality in those treated with ribavirin. 2013, there was an outbreak in a children's oncology unit with possible measles. I will say that their testing or the confirmation for all the patients that were included in this was not the best, because some of them actually tested negative, and I think they were just treated presumptively, but treated with oral ribavirin. And they noted that there was a delay. If there was a delay in starting ribavirin greater than 24 hours after the rash, was associated with fatal complications. So 2 children that were not treated with ribavirin within that 24-hour period passed away versus the 13 that were. And then they also did administer ribavirin as kind of prophylaxis in 21 other exposed cases, and noted no infection in those cases. So these are limited studies, small case numbers, diverse routes of administration, dosage and duration, inconsistent confirmation of measles diagnosis, or at least reporting within the text itself, and inconsistent study design. So those are definitely limitations, but I would say it is kind of promising in terms of what the outcomes seem to be. Um, some other things that have been tried, interferon alpha, also interferon beta, which I didn't go into because alpha is the one that's used a little bit more. But there was a pilot in 1998, randomized controlled trial of low dose oral interferon in 30 pediatric patients, and again showed shorter duration of constitutional symptoms and rash in that group. And there have not really been any use or any studies of interferon kind of since then. I think people tend to go more towards the ribavirin route. Remdesivir has been considered as another kind of thing that like in vitro seems to delay measles replication as a nucleoside analog. It has been had only kind of case report use. Very few, at least reported uses in cases of SSP. And again, that's that like progressive neurodegenerative disorder that appears years later. It does seem to maybe delay some of the changes in which they're observing like postmortem on brain biopsy. Just looking and trying to like look at what the measles type looks at that point. But again, it did not prevent progression of the disease. Inosine Pranabex, this is not available in the US. It is approved in Europe and in I think Africa and parts of Asia. This also has shown maybe some promise. 1998, there's a multi-center study. Again, they're trying to treat SSPE with inosine plus interferon versus inosine by itself. Overall, again, like still pretty high mortality. And there can be, and I didn't mention this before, there can sometimes be spontaneous remission or like relapsing remitting course of this disease sometimes. But they felt like, but with both groups, both the interferon plus inosine or the inosine itself group, they had a slightly higher spontaneous remission of 30% higher than reported in literature. Again, there was no placebo group in this study. But then 2026, and again, these treatments have had limited use in measles encephalitis or MIBE. They did use inosine Pranabex in a 3-year-old child with BAL who actually had complete recovery. And so that's a recent publication and possibly promising, but again, a single case. Other things, steroids plus or minus IVIG, often used in measles encephalitis cases, but there's not really good evidence for its efficacy. And still, when it's used, it often has prolonged duration of symptoms greater than 3 weeks. And what else might be coming? A couple of things, hopefully in the next couple of years, at least we'll see the monoclonal antibodies, is what it sounds like, but they do have small molecule inhibitors targeting measles virus that are in preclinical animal studies with some kind of promising results. And then again, monoclonal antibodies, there was a recent paper actually out of La Jolla Institute kind of further defining one of these fusion proteins as a potential target for monoclonal antibodies. And there's a company, Invivyd, already starting to test a drug as of April with possible release to the public if things go well in the next 2 to 3 years. So of the treatments that we have, I would say, and we'll see how these go, but outside of really ribavirin and maybe vitamin A in the pediatric population, we're very limited. And so new investigative, innovative therapies are going to be really important. So key points. There is a current reemergence related largely to declining vaccination rates, especially in the Americas. Immunocompromised patients, especially with T-cell defects, are at higher risk of complications and mortality. B-cell memory wanes over time. Revaccination can be considered, but the data behind it is not great. So it's just a very soft recommendation outside of the adolescent period when it is saying like after immune reconstitution, do revaccinate. Post-exposure prophylaxis should be used, probably effective, but it's just poorly studied in adults. And then overall limited evidence of treatment. Vitamin A still is part of the WHO recommendation for children and adults. Ribavirin has some efficacy to reduce complications, although the studies are limited. and some things are on the horizon. So lots of references. That's it.
Sorry, that's me clapping. Um, that was really informative, Adriana, and obviously very timely with some of the things that we're seeing, maybe not quite locally yet, but could be locally. And Adam, Nettie, and I think all had similar questions because there was a period of time, and it feels like it was 8 or 10 years ago when there was a little bit of a resurgence, looking up whether there was I know you started talking about this, but looking up whether people needed to be revaccinated who were living with HIV. And I know we were standardly doing it in the mother-child in the adolescent program. Um, Even if we had their vaccine record, but I know that's what Nettie's saying, that if they had two vaccines, that sort of trumps it. The problem was we didn't always have those records. So we were doing measles, IgG, and and I wish I had numbers. We were definitely finding people without, with no evidence of immunity. And so we were vaccinating those people. It definitely didn't completely, I think we started, I'm sorry, I'm speaking and it doesn't make a lot of sense. I think we decided to check people's titers regardless and found that there were some people where the immunity had waned, but we didn't do anything sort of robustly on it. I guess the question right now is how would you approach that across, a clinic, a whole clinic? Would you standardly recommend everyone gets a measles IgG, look at someone's vaccine record, and then if they were, if they didn't have immunity, would you revaccinate and how much?
So it's hard in the adult population because we know that you generally have B cell waning immunity that's just related to like the cells kind of decreasing in time, but we're not good at measuring T cell immunity, which still might be present. And that's what we think like is still able to have a good kind of abortive response in the case that you're actually exposed. So I think that's why the idea of if you have had measles vaccination in your record, that is adequate enough because we aren't effectively able to check the T cell memory. As far as like in the case of exposures or an ongoing kind of epidemic, or if something were to happen in San Diego, there isn't like any clear kind of recommendation moving forward. And hopefully in that case, public health would be able to put something out to like drive what those recommendations are. I know even earlier when we were starting to get reports of, I think last fall, like a group of students that were homeschooled, there was like seemed like there was an outbreak kind of ongoing about that, and I know parents were calling in trying to figure out what to do. I think generally if there was a known exposure, checking vaccination records, and if it is within especially the 72 hours, if they have good CD4 counts, I think it's the really big driver there. I would say vaccination is the best kind of preventive still if we don't have any record of vaccination, or if they had HIV later in life and then became immune reconstituted. I would say that's something to consider, but there is no recommendation at this point in the adult population. So
Actually, Laura says, I don't know if Laura, you want to jump in here. I didn't remember this from the new primary care guidelines.
Yeah, that actually it's I think came out 5 years ago. The
And
like the
not new.
2021 update. Yeah. So it is recommended again in all people with HIV to check an IgG if they were born after 1957. Even if you can confirm vaccination and then revaccinate if CD4 count is over 200. So I think we've largely been doing that at Owen. And like you said, Jill, I've found a number of patients who are not immune, so revaccinated. I don't know if others have as well.
Can I chime
And
in with
you
the
did two
dissent?
doses, right, Laura?
Jill?
2 doses.
I'm sorry, Jill?
Sorry, 2 doses.
2000, 2 doses. Yeah, 2 doses,
Yeah.
4 weeks apart. Yeah.
Yeah. Sorry, Nettie, go ahead.
I just wanted to chime in with a dissent because actually what I was saying was that my understanding outside of HIV and looking this up for employee health purposes was that the studies of the vaccine were done with vaccine efficacy, and we don't have a like cutoff for titers, and so titers are not to be used to determine immunity unless you don't have any other way to determine immunity, right? So the data was on 2 doses and was so strong that even if you have an employee who's received 2 doses and somebody ordered a titer anyway, you do not give them another dose. So that was, again, that's outside of HIV and that's from 2019. But that was my question, was there's a lot of talk about using serology, but unless we know what the serology means, sometimes we end up sort of using it, making assumptions about serology, right? We did this with COVID or whatever. We just go to say, oh, this shows you're immune or not. And then the cutoffs weren't all that clear. So I actually was not aware, or maybe I was aware, but decided to ignore it because of this other perspective of mine. But I think taking somebody who received 2 vaccines and has documented immunity and revaccinating them or checking IgG on all of them is probably overkill. So I'll take a little bit more look at that, Laura. But I think if we start checking titers in everybody who's had 2 vaccines, we're probably going to be giving a lot of unnecessary vaccines. And it's not a completely benign vaccine.
And I saw what Fernanda wrote about not a completely benign vaccine. And for people who give a lot of vaccines, I've certainly never seen anything like that. So I think I'm going to go with this. Could be a great debate. Maybe we have to send this to ID Week as, follow these guidelines or not. And I'll nominate Nettie and Laura to go head to head. I'm just kidding. Adriana, do you want to respond to all of this?
Yeah, I mean, I would agree. I would say like IgG levels, we don't always know what to do them or what the good cutoffs are. And so that's why those alternative kind of proofs of vaccination were developed. This is sort of an aside, but this comes up at least in the pregnant population. A lot of times they check rubella antibodies, and the question, like the assumption a lot of times is that patients are immune to measles just with that, and that actually there have been studies that show that that's not true, that rubella is like also very common in the community. You can have immunity to that without actually having been vaccinated, so it can't be used as a surrogate. But yeah, I would say evidence of vaccination already in the context of waning immunity, we're not having a good test of T-cell immunity, and probably people already have good protection. As far as the vaccine goes, I would say that it's, as long as people have solid immune systems, you can get local reactions. Sometimes you can get a little bit of a disseminated rash, and like up to 5%, but it's well tolerated, and importantly is going to prevent the complications that you would get with wild type measles, and specifically SSP you cannot get from the vaccine strain. So
I was just screening the 2024 guidelines. Anyway, so just put in the recommendation. That was exactly what Laura said. Adam says, one practical consideration, though, with rising cases and lots of summer travel with the World Cup, I wonder if it might help reminder front desk. Go ahead, Adam. I see that you're there.
Yeah, no, just because I feel like things are a lot more loosey-goosey after the height of COVID. And if I had a nickel for every time the patient's like in the room, they're like, oh yeah, I have a cough, or conjunctivitis, just because this would be terrible, right? If you have an outbreak at the HIV clinic with all our vulnerable patients. So the data really made me think of that. So thank you for sharing this really timely talk.
Yeah, that's been coming up a little bit more about measles and current travel over the United States, both in and out. We're probably exporting some, unfortunately. So
let me make sure I didn't miss anything that was said above or that was noted above. I don't see anything that I missed. Does anyone else?
Quick question to Laura about this, where you pasted it in here, Jill, and it says should be tested by measuring antibodies. Then it says MMR vaccines should be given if they've not received the vaccine, or have immunity, which is kind of interesting because the definition of immunity is receiving 2 vaccines, but I guess they're saying have sufficient antibody levels as well. Do you think that's what
that's how I would do it.
Yeah, it recommends checking IgG. I mean, I guess we can debate. I think to Adam's point, we see a lot of waning immunity, right, for hepatitis B and other other viruses.
Yeah, Hep B is the only one that we like know what the titers mean though. That's why, you know what I mean? Like, so that's what I
Yeah.
always tell people. The only one where we know what the titers mean is Hep B. So we'll take a look and see
Hold
what
on,
they were basing
Nettie,
those
we
titers on.
thought we knew what they meant, and now that's all come into question now, right?
Right.
That's the next age rounds. That's the next high rounds, Jill. We'll talk
I
about that one.
agree. I agree. No,
Yeah,
the
because
thing is,
I have so many patients where I would have thought to recheck their surface antibody, and of course, like people get admitted to the hospital or someone else rechecks, and I'm like, man, they're less than 10, so no, wouldn't have rechecked because their immune status didn't change. So I agree, like
yeah,
all bets are off.
it's tough, and I'm sure the pendulum may swing back in a different direction at another time where, we learn that this didn't do anything, and so then there's no recommendation. But agreed that this is a relatively safe and easy thing to do. And I think as infectious disease and primary care providers of people living with HIV, we know that prevention is the best way to do things. So I don't know, we do a lot of wasteful things, and maybe an extra 2 doses of MMR is not a huge deal in the grand scheme of things. But I love this lively debate. I think that's it. Adriana, thank you so much for this. I was telling her that she was rounding out high rounds for the academic year, and I think this is a nice way to go out with something that um, is maybe knocking around the corner, but it's not here yet. And these are, we just have to be on our toes a little bit about this. And just something that we should all be prepared for. And as Adam notes, after the World Cup, I would also note after big events over the summer where people gather. So thank you so much. I also just wanted to take one moment. This is not meant to be about me, but I'm going to make it about me for a second. This is my last hosting high rounds, unless I'm called back up just for help in the future. I've been doing this for 10 years, and I said, I think it's time to pass the torch on to someone else. Right now, there isn't a person the torch has been passed to. And so Anik and Dan are going to continue to support things. But hopefully starting in August, there'll be a new additional person to the group. But it's been really fun doing this, and I feel like I've learned so much from all of you, and it's been a great way to get to know different people. So I appreciate everyone, and sorry, it wasn't meant to be a big thing other than, yes, we'll have a party at some point. So, but a party for everyone. Okay, and Sarah just found something else. I don't know, on a different page of the guidelines. It says immunity defined as patient born before 57 or as documentation of receipt. So maybe you're calling into question if someone needs the titer if they've been vaccinated.
Correct.
Okay.
I would
Let's
I
all
would
think about.
I would
Yeah.
paste it into the chat. I'm sorry, but I'm on the call on my phone, but I'm looking at it and still through the HIV guidelines. So I think the debate is partially because not all of us are doing the same thing, and then if we say there's guidelines, like we should all be doing the same thing. Right.
But maybe that's why it's a little bit confusing, because the guidelines are slightly confusing.
Right,
Yeah.
right, and the documentation of having 2 MMR.
Yeah. I think that's one of the hardest parts, right? Unless someone is a California born and raised, you may not have accurate information. So,
Right.
and I think if you don't have documentation, or you're like, and this happens with me a lot, hey, send me your documentation. Oh, you have it at home, send it through my chart. That may or may not happen. So yeah, that's maybe why we're defaulting to just do it. But maybe that is good to know that if you see that there have been 2 vaccines, you don't need to check the IgG level. So anyway, just wanted to close up that note. Thank you, Sarah. And yes, thank you, everyone. Yeah, no, it's almost 9 o'clock. So 3 minutes back. Enjoy July. I think we reconvene, Marvin, am I right? August.
It'll be the first
7th?
Friday in August. Yeah.
Yeah. And Sorry, and as I'm leaving, I think something I was going to bring up with the group is, our in-person rounds have gotten a little bit challenging still, although we just recently had a great ones. I was thinking that maybe that quarterly it is only offered in person. And this is something the whole group can debate. But maybe we really try to do that so that we quarterly are all together and you can have it like on your schedule in advance. But anyway, that's something for the next group to consider. It is so nice when we all are in the same room, and I think it changes the way this all looks. So anyway, have a great rest of your day and summer. See you in August. Bye, everybody.